This is Baskaran Ranganathan, ENT consultant from Manchester. So my next video is about, I'm covering two topics. One is septal perforation and anosmia. So septal perforation is an important topic. It could be asked in the viva, or you may get this in the clinical examination section. So if you've shown a video, if you're shown a photograph, just explain what you could see, approximate size, where the perforation is seen, and how the mucosa around the perforation is looking. I'm not going through in detail about the causes of septal perforation, but if you can have some broad classification in your mind, like trauma infection, neoplasm, idiopathic, and substance abuse, so it'll be easier for you to explain the causes if you just know this broad classification system. In your history and examination, your history should focus on the causes of septal perforation, which you've seen in the previous slide. So the history should be based on that. Any recent surgery, injury, substance abuse, medical history. So those sort of history, and the patients are going to mainly present with symptoms of crusting, bleeding, and if it's a small septal perforation, they may have a whistling noise, which the others can hear, especially at the night time. And if the perforation is large, it can start altering the shape of the nose. Commonly, they can get a saddle-shaped nose stop. And then in your clinical examination, you're going to look with a pterygium speculum with a headlight, look at the size of the perforation, where it is located, and how the edges of the perforation is looking. And then it's important to do an endoscopic examination as well, just to see how the other aspect of the nasal cavity, including the nasal mucosa, turbinates, and also the postnasal space. Also, even if it's in the clinical scenario, in the clinical examination station, I think you need to look at the shape of the nose as well to see is there any obvious nasal deformity. If you know there is an obvious cause, like the patient recently had a septoplasty, and then he comes with a septal perforation, with the mucosa appears healthy, then you don't need to do any further investigation because there is an obvious cause for that. But if you're not sure about it, then you can request this battery of blood tests, including ESR, ANCA, AC levels, and autoimmune screen. Biopsy, again, this is not routinely required unless if there is any suspicious finding, like if you look at the edges of the perforation, which looks very granular, or the surrounding mucosa doesn't appear healthy. If you have an eye index of suspicion, then only you may need to take a biopsy, which can be done in the clinic under local anesthetic spray. So how are you going to manage? The three management options: conservative management, septal button, and surgical closure. Most septal perforations can be managed conservatively. What they need is regular use of saline nasal douching and topical moisturizer like KY gel or Vaseline. They can use it regularly to keep the nasal mucosa moist. And once the edges of the perforation heals, probably most of the nasal symptoms will start settling down. Septal button, I'm not a fan of septal button, but in many departments they use septal button, and recently they've introduced like a celastic sheath with a magnet in between. That's also can be safely used, and I would reserve those for large septal perforation and if the patients are getting excessive crusting and bleeding. Surgical closure is possible, but again, this depends on where the perforation is positioned and the size of the perforation. Ideally, if this is less than 2 centimeter, then the surgical closure, the success of the surgical closure is high. if it is about 1 to 1.5 centimeter, and we can achieve closure in 80 to 90% of the patients. So again, there are various techniques have been described, but traditionally an open septal rhinoplasty approach, mobilizing the nasal mucosa above the perforation and under the upper lateral cartilage, and also going inferior to the septal perforation and elevating the mucosa from the floor, and also under the inferior turbinate and mobilizing the mucosa and approximating it, and position and placing a cartilage graft. Commonly, we use conchal cartilage interposed in between these two septal flaps. So that's a traditional and it's a traditional way of doing this surgery with a good success rate. Again, I mentioned about it all depends on the size of the perforation. Recently, endoscopic approach, what they do is they elevate a flap based on the anterior ethmoidal artery, swing that flap and close the perforation. So it is just a single mucosal flap closing the perforation. We don't know the long-term the success of this endoscopic approach, but this seems to be getting more popular. So you can mention that you have these two approaches, and you can mention with whatever you're comfortable. So this is about septal perforation. The next important topic is anosmia. If you remember, and if you can broadly classify them into two, like a conductive loss and a neural loss, like how we describe it for the hearing loss. It's the same principle. Conductive loss means when the airflow is not reaching the the roof of the ethmoids where the olfactory receptors are situated. The conductive loss is mainly because of an anatomical abnormality, like a significant septal deviation, or an infective or inflammatory pathology like allergic rhinitis, chronic rhinosinusitis, or a nasal tumor which can obstruct the nasal airflow as well. So that's a conductive loss, and the neural loss is because of disturbances within the receptors or in the olfactory nerve itself. So head trauma can cause fracture in the cribriform plate, which can sever the nerve, or most commonly the viral recent upper respiratory tract infection, and the patient goes into hyposmia or anosmia. This is due to the destruction of the olfactory receptors. There are other rare things like olfactory neuroblastoma, neurodegenerative disorders, and the other thing is like you may not even find the reason why people do get anosmia, like idiopathic. So the history is going to be targeting on the causes of anosmia, like if it is a sudden onset, as I earlier explained, sudden onset, like how I explained before, either due to head trauma or recent upper respiratory infection. There is a gradual loss in cases of neurodegenerative disorders. There'll be a fluctuating hyposmia, anosmia, and also getting a normal sense of smell. This is typical of inflammatory or an infective pathology. And it's important to remember that olfactory disturbances are always associated with the taste problems as well. So patients will have present with both problems. So examination should be a thorough examination, like how we do a nasal examination, photochemical speculum, endoscopic examination. The endoscopic examination, it's important to visualize the olfactory clouds. See, is there any swelling or is there any signs of infection or inflammation? Investigations, there's always a discussion about whether what we do, whether a CT or an MRI scan. I think if there is your examination shows there is an obvious evidence of infection or inflammation, then you should go for a CT scan. that will show that any mucosal pathology there, then you're going to address it whether medically or surgically. If your nasal examination is absolutely normal, you're able to visualize the olfactory cleft, which again appears normal, then you can go for an MRI scan of the anterior skull base to rule out any olfactory neuroblastoma or any other intracranial pathology. The other investigation is smell testing. There are many varieties, many tests are available, but I think the most common ones are upset and the sniffing stick. This is more theoretical and a research purpose, but you can be given this, you can be shown a photograph of this and they may ask you to explain. So it's worth spending some time to read around these two tests. I think just have some brief explanation how you're going to do this test. I think the common ones are the upset test, which basically has got a 10 envelopes with each containing 10 scratch and sniff tests. So how treatment of anosmia. This again depends on what you could see on your endoscopic examination and in the CT scan. If there is anatomical deformity, like a septal deviation, do a septoplasty. If there is an infection or inflammatory causes, then you manage it as accordingly. So if there is a nasal polyps, you can offer them endoscopic sinus surgery. There's been various other treatments have been tried. I think among them, I think the smell training seems shown some evidence of improvement with the symptoms. So this is available on the Fifth Sense website. All they have to do is to buy odor oil, and they have to choose 4 odors, and they have to do this, smell this at least twice a day for a period of 4 months. I think there's been some good evidence of improvement with the symptoms. The other treatments, like as I mentioned before, they've tried vitamin A drops, zinc gluconate, intranasal steroids, and oral theophylline, but none of them has shown any long-term benefit. It's also important to explain to the patient about the safety aspects, like to fit carbon monoxide alarm in the kitchen, and they need to label their food so that they're not eating any rotten food and causing infection. So I think that's also important to cover. Thank you. I hope you've enjoyed this video. We'll see you in the next